Thank you.
Good morning, and thank you, sir, for the kind words of introduction. I really didn't want you to read everything on the resume. Right. So today we are going to discuss about the updates in the management of acute ischemic stroke. So I know all of you have seen patients with stroke, and most of these patients are having some kind of disability. So why is that? And why we should talk about a stroke? Now, the reason being, the brain doesn't have any regenerative capacity. Therefore, if we lose any neurons, they are gone. So brain has some adaptability, or we call it neuroplasticity, but doesn't have any regenerative capacity. So in a typical supratentorial or anterior circulation stroke, let's say about 50 ml stroke volume, capacity of the stroke. Now, this is the amount of nerve cells that we are going to lose. So every second, we are going to lose about 32,000 neurons per minute, per hour, and once that 50 ml stroke is established, we are going to lose about 1.2 billion neurons. So they are dead, they are gone. So the notion here is time is brain. So we need to act fast. If there is any delay, we are going to lose neurons. So the patient is going to end up with permanent disability. So this is basically the take-home message. So we need to act fast when we are going to treat patients with stroke. So over the next hour, we are going to go through epidemiology and few basics of strokes because of our junior doctors and the medical students, and how do you assess a patient who comes with a stroke in acute setting, and also neuroimaging methods, then the thrombolysis, thrombectomy, a couple of words about wake-up strokes, and then the decompressive hemicraniectomy and the early post-thrombolysis care. So this is about the management of acute ischemic stroke. Right. Little bit about the numbers and the figures. Now, stroke is a leading cause of disability and death worldwide. So, in one of the Sri Lanka studies, which was published in Journal of Stroke and Cerebral Vascular Disease in 2020, it showed that it is the 5th leading cause of deaths in hospital in our country. And the stroke prevalence is 9.6 to 2.4 per 1,000 population in our population. And these numbers vary in the different community and the presence of NCD risk factors that are present in the community or the cohort that is tested. Right. So, what is stroke? Now, stroke is acute onset focal neurological deficit which lasts more than 24 hours and presumably due to a vascular insult. So that is a basic definition of a stroke. Then what is the TIA? So TIA is basically for medical students. So the TIA is, it's an acute onset focal neurological deficit which improves within 24 hours. So basically 24 hours is it's basically an arbitrary cutoff that is basically differentiate whether it's a stroke or a TIA. But if you read the NIVA textbooks or the NIVA text, the definition of TIA is different. The reason being, even someone has a tiny, let's say, weakness or numbness, which has improved, they might have permanent ischemic area in the brain. So that is actually not a TIA. But for practical epidemiological purposes, if the patient has completely improved within 24 hours, we take it as a TIA. Okay, right. And then types of stroke. So there are two types of strokes: hemorrhagic or the ischemic. Out of two, ischemic stroke being the commonest. About 80 to 85% of the strokes are ischemic strokes. Mainly the two reasons, or two causes for the ischemic strokes are thrombotic or embolic. So thrombotic strokes are usually due to atherosclerosis affecting the major vessels supplying the brain. So the anterior circulation, the carotids, intracarotids, common carotids, or the posterior circulation, vertebral or the vertebral basilar circulation. The embolic strokes usually start from either the great vessels, ruptured plaques, or from the heart, as in atrial fibrillation, where the patient can develop left atrial thrombus, or left ventricle mural thrombus following low ejection or following myocardial infarctions, where the emboli could shoot from the heart. So those are the two common reasons, the pathological processes by which thrombotic and the embolic strokes can occur. I mean, beyond that, there are so many other causes for strokes which I'm not going to touch here. So these are the common causes for the ischemic strokes. Right, and the patient's signs and symptoms would depend on which part of the vasculation. Now, if you look at the image on the left, right, this is the vascular supply of the brain. So you have the posterior vertebral arteries, anteriorly anticirculation, common carotids, then the intercarotids. They join and form the circle of Willis, from which you get the anterior, middle, and the posterior cerebral arteries, and also branches of the vertebral system. So that supply basically the brain, and there are different vascular territories depending on the artery that we are concerned. So depending on the block in any of these arteries, the different parts of the brain get ischemia or the infarction. So patient gets a different set of signs and symptoms. So the preferred or the imaging method that we do in acute stroke is going for a non-contrast CT scan of the brain. So basically this is to differentiate whether this is a rupture of blood vessel, that's a hemorrhagic stroke, or a ischemic stroke. Now in a ischemic stroke, the area looks more hypodense or more blackish or grayish, whereas the blood is seen as white. So what I put in the right top corner is how do you see the different densities in a CT scan. So in a CT scan, the denser material is seen as white. That's why the calcified materials, the cortical bones, they are seen as whitish area. So these calcifications and these are the cortical bones seen as white, and also blood is also seen as white. Whereas areas with lesser density are seen as blackish areas. So you see the more blackish area in the CSF, and the air has the highest the blackness. And so these are the two types of stroke that we commonly see: hemorrhagic stroke or the lobar ischemic stroke. And you might see sometimes a patient develop very tiny areas of strokes in the deep part of the brains. Those are called the lacunar strokes. So the strokes are ischemic strokes are seen as blackish areas in the CT, whereas hemorrhagic strokes are seen as whitish areas in the CT. Just a few words from the words about the terms about the strokes. Now, this is important when you go further in the discussion. So, when someone gets a ischemic area, when the artery is blocked, the central part gets the most ischemia here. So that is the ischemic, the core of the infarct. So this is the area where the cells are having the most ischemic, and that's the area where the cell loss or the cell death happens. So that is surrounded by area called the penumbra. It's an important word for us. Penumbra is area ischemic, but still the cells are not dead. Still we can save these cells, and out of that is the oligemic area, still less blood flow, that they are not dead yet. And then the normal, the brain. So once the stroke is established, we can't do anything for the infarct core, that is already dead and gone. What we can do is to save the penumbra. So earlier we act in the management in the stroke, we can save the penumbra. So we can limit the patient's disability, the neurological disability of the patient. So that's the main aim, or that's what I mentioned as the time is brain. So if we act early, we can save the, or we can at least minimize the penumbra converting to infarct. Right. So when you talk about the early management or the acute management of stroke, there are a few things. So first thing is early detection. Then we decide how severe the patient's stroke is. Now, most of the strokes happen in the community. Therefore, rather than doctors, we need to inform the public. Otherwise, when the public comes to you, maybe after 3 months, 6 months, and they will bring their loved ones coming and saying that my father or mother having stroke for 6 months, can you do something? So that is not the time. We need to act quickly. Therefore, the public education is very important. You might have seen these posters, FAST. FAST is face, arm, speech, time. Face is when there's a facial droop or the facial asymmetry. A is for arm, that is arm or leg weakness, unilateral weakness. S is speech, that is speech difficulty or dysphagia or in dysarthria. And if the public sees a patient with any of these signs or symptoms, they can quickly call 1190, the suicide ambulance, and they'll take the patient to the nearest hospital. So it's important for them to understand that they call an ambulance or they find their own vehicle and bring the patient to the nearest hospital, rather than taking the patient from here to Colombo and saying that Colombo has a better stroke care. So they come to the nearest hospital. At least they can, they might be able to thrombolyze these patients. So every year, on the World Stroke Day, that is the 29th of October, Association of Sri Lanka Neurologists and the Stroke Association, they do stroke walks and the stroke programs and public awareness programs to let the patient know, if you take the patient quickly to the hospital, there's a chance then we can reduce the patient disability. Right. So regarding the assessment, so the picture is not very clear here, but if you Google it, NIH score, there are a lot of apps as well. You can see how we assess a patient who comes with a stroke. So we check about the patient's level of consciousness, the weakness, the visual symptoms. Likewise, there's a chart we can mark. So depending on the severity, we can put a score to the severity of the patient's the signs and symptoms, and then get a severity of the score. So if there are no stroke symptoms, NIH score would be 0. So if there are minor, if the score is 1 to 4, patient has minor symptoms, then moderate is 5 to 15, moderate to severe 16 to 20, then severe stroke is more than 21. And if you go to the web and if you go to MidCap, there's an app for the NIH score as well. So this gives you some idea about the severity of the stroke. So this is important when we are going to plan the patient's further management. Another scoring system is a MRS or the modified ranking scale. So this is a very crude method of looking at the patient's disability, how disabled the patient is. So 0 being patient is asymptomatic or patient doesn't have any symptoms, whereas 6 is dead. In between, depending on the patient's severity of the symptoms, they have a different scale is given. Right. So first, when this patient comes to hospital in the acute state, what we do is we examine the patient and we get the patient's NIH score. So we here, so we have charts in the A&E, so we use, and then we mark and we get the patient's severity of the stroke, and then we decide on whether patient can be thrombolyzed or not. And then the imaging method. Now we go for the non-contrast. Now we go for the non-contrast CT of the brain, as I told you previously, to look to differentiate whether there's a hemorrhage or not. So if the patient is having hemorrhage, it's no point of thrombolyzing the patient. So we are going to make things worse. So if the patient is not having ICH, then we think this is a ischemic stroke. Right. Now, in a non-contrast CT, it takes maybe hours for the ischemic changes to appear. Sometimes it can take 12 hours or even 24 hours. Therefore, having a normal non-contrast CT scan of the brain does not exclude ischemic stroke. So this is something important point. So if someone asks in the exam, why do you do a non-contrast CT, that is to exclude a ICH. It's not to diagnose ischemic stroke, because ischemic stroke does not show in the early phase. But that does not exclude patient is not having ischemic stroke. Therefore, we have to look for some early signs of stroke. Now, if you look at the scans here, they are not really clear, I guess. There are a few signs that we look for. One is the insular ribbon sign. Now, if you look at the right insulator, so this insulator of the brain, you can see a little ribbon-like area here. So, little whitish area. But if you look on the right side, you don't see it well. So that is called the loss of insular ribbon sign. So that means this side patient is developing early ischemic changes. And also, because of the early onset of there will be a little bit of edema with the early stroke, there may be some loss of the Salsai-Guida pattern. That is called the effacement of the Salsai-Guida here. So these are few early ischemic changes of the brain. They are very difficult to locate. And then there will be a loss of gray matter demarcation. Now here you can see the head of caudate and the putamen, white, the deep nuclei here, but on this side they are not really clear. So this is another early clinical feature of a ischemic stroke. After a few hours, maybe after 6 or 12 hours, then the ischemic changes start appearing on the CT scan. So this is not the same patient, it's a different one. Okay, the images C and D. So here, this is the early image. You don't see much changes, but you can see the effacement of the sulci and gyra here. But when you repeat the scan after about 6 hours, now you can see the stroke has established. Now this is the time here or here. This is time where we are going to thrombolyze these patients. Not once this is established. Once that is established, we know it is more than 6 hours. Right. Another early sign that you might see in the scan is what is called the hyperdense MC or the middle cerebral artery sign, where we can see the thrombotic material blocking the artery. Sometimes this could be an artifact because if there are calcified arteries, they might be seen as the hypertension sign. Now all these signs should be taken according to the patient's clinical history and the examination findings. Right. So the next thing that we should do is to see how severe the stroke according to the imaging modalities. Now I told you can look at the early changes here, and then we can give a score according to the severity, according to the area that is affected. So brain is divided into, we take two coronal sections of the brain at the basal ganglia level and the corona radiata level, and then some areas are given a number, and the radiologist look at these areas and they give a score. So if the area is not affected, they get a score. If the area is affected, they get a 0. So these are the areas that are marked, and then we get a score out of 10. So score can range from 0 to 10. And if the brain is completely normal, there are no ischemic areas, the score is 10. So each area that shows ischemic change, 1 point is subtracted. Therefore, if the stroke is severe, that is it's an extensive infarction, the score would be lower. So that is called the aspect score. And there are automated system as well. Those automated systems can automatically, when we do the CT, it will automatically tell you the aspect score. There are AI methods as well to calculate the early stroke severity on the CT. Right. The other imaging modality that is important is the CT angiogram. Now, we don't do all these test investigations for our patients because of the limited resources. If you are going beyond the usual care, then we need to do the CT angiogram and look what kind of arteries that are blocked, and if so, any interventions can be done for these patients. So here you can see the common intercarotid and then the anterior cerebral, medial cerebral two branches. Here looking at the vertebral basilar system, vertebral arteries, basilar, posterior cerebral arteries, and here middle cerebral arteries occluded. So beyond that, there's no flow. So if you are going to do intervention, this is the place the intervention should be done. Right, now we are going a little bit more deep into the neuroimaging. These are things which ideally should be done for patients who come with a stroke. So I discussed about the routine CT scan and then the CT angiogram, and then comes the CT perfusion. And the CT perfusion imaging is to see how much the perfusion is affected. So in a normal artery, the artery is full of blood and patient gets the full the vascular supply. Now when there's a block, there will be less amount of blood. So what will happen to the brain? So here it's a graph, cartoon, which shows in a normal state CBF is cerebral blood flow, CBV is the cerebral blood volume, MTT is the mean transit time. Now cerebral blood flow is normal when there is no block, and when there is some degree of blockage in the arteries, the cerebral autoregulation sets in and it keeps the cerebral blood flow, and the autoregulation will increase the blood volume to keep the cerebral blood flow, but it's going to take a little longer time. Transit time is going to get increased, but still there's no ischemia because autoregulation is keeping the blocked area perfused. But if it progresses further, now the compensation loses. Now the patient, the brain area is getting decompensated. Now then starts the oligemic phase. The graph I showed, the picture I showed previously. Now the cerebral blood flow start to come down. Still the cerebral blood volume is maintaining. Now it's going to take more time for the blood to flow. Then comes the penumbra. Now penumbra has reduced blood flow. Now the blood volume is coming down, but the mean transit time, or it takes more time for the blood to go to the ischemic area. Now when the ischemic, the infarcted core sets in, the blood flow has gone critically down, blood volume goes down, and the mean transit time goes up. Now here is the area where the cell death or the necrosis happens. Now this is the basis. So this can be checked in the by doing advanced imaging. So the advanced neuroimaging, we look for the CT perfusion scans. So the CT perfusion scans will show the things I told you previously: cerebral blood volume, cerebral blood flow, mean transit time, also the Tmax. Tmax is the maximum time that is taken for the blood to travel. So here, if you look at this image, 0 is this is less, this is the maximum blood flow. The right side, the brain is perfused, whereas left side is not perfused. It has a blood volume of it's like 1 to 0. Now here, so the blood flow also reduced. So the mean transit time, so it is very high here. And then if you take the Tmax, that is also increased. So the CT perfusion images will get you will give you some idea about how big is infarct and how big is the penumbra. So that is important. If you know the size of the ischemic core and the penumbra, then you can plan the patient's management. If there's no big penumbra and if the ischemic core is already large, then going for advanced treatment method is not going to work. But if the ischemic core is less, whereas penumbra is big, that means we can intervene and we can save the penumbra. So that's why we go for this advanced imaging to see whether there are any salvageable areas in the brain with the perfusion imagings. Another imaging method is the MRI. So the MRI also we can do the DWI or the diffuse weighted imaging and the FLAIR images. Now fluid attenuation, inversion recovery. So these images are also helpful in differentiating early ischemic changes and see whether it is established or not. We do these images because the non-contrast CT, as I showed you previously, is not going to show you the early ischemic changes. Right. Now, how are we going to manage our patient? So there are three aspects in the management of the acute ischemic stroke. One is the stroke unit care, thrombolysis, and the thrombectomy. So number 2 and 3 are the reperfusion methods. Now, when you talk about the stroke unit care, so that is the single most effective intervention in the management of acute ischemic stroke. So that has been shown, proved in the meta-analysis that if the patient goes into a stroke unit care, even though they have not been thrombolized, the patient has a good recovery. So stroke unit has a multidisciplinary team, and they monitor and correct any abnormal physiological parameters that would limit the neurological deterioration of the patient. So what are the components of a multi-MDT or the multidisciplinary team in a stroke unit? So it has a doctor, nurse, there's a pharmacist, there's a psychologist, psychotherapist, occupational therapist, speech therapist, and then the social worker. So all these people get together and work to a single goal to improve the patient's functional outcome. So the things that we should look at the patient following the acute stroke care is the oxygenation of the patient. So the supplement of oxygen, if it is less than 95, this is for normal patients. If they're having carbon dioxide retention, I think it's 82. Then hydration, oral or IV. Hydration is not good because it can worsen the cerebral edema. And then control of temperature, management of blood pressure, and the blood glucose. Both hypo and hyperglycemia both are neurotoxic. Therefore, keep the blood sugar without getting into very tight control. And the thromboembolism prophylaxis, usually with the mechanical methods in the early stage. And then the head positioning in first 24 hours for 30 degrees to reduce the brain edema. So these are the basic things which can be easily done when you are treating a patient with an acute ischemic stroke. Even in the ward setup, these things can be done. Right, I'm going to talk a little bit of the blood pressure management because the high blood pressure disrupted cerebral autoregulation. Now, I showed you previously cerebral autoregulation is important in the early stage in the acute stroke management to control keep the patient's cerebral blood flow. So, if you think, let's say, your patient has a blood pressure of, let's say, 160/90, and you think it is very high, and you quickly reduce it. Then what will happen is the penumbra and the oligemic area is going to get infarcted, because those areas are perfused by the increased blood pressure from the autoregulation. So keep in mind, you are not going to control the blood pressure unless systolic blood pressure is more than 185, diastolic more than 110, where the mean arterial pressure map comes to about 130. Or the patient with hypertensive encephalopathies, seizures, or cardiac failure, aortic dissection, AKI. So those are the instances where you would control the blood pressure acutely. Otherwise, you should control the blood pressure very slowly. Usually the target is reduce blood pressure 25% in 24 hours. And if the patient is already on antihypertensives, that can be continued once the patient is stable from the acute state. Right. So then comes the reperfusion therapy. So the reperfusion therapy has two goals. One is immediate goal is restoration of blood supply. So we can reperfuse the penumbra, and we can save the cells that are ischemic but they are still not dead. And the long-term goal is to improve the patient's outcome by reducing the disability and the death following the stroke. Right, so the reperfusion therapy has two aspects: intravenous thrombolysis, IVT, or the mechanical thrombectomy. Now, the thrombolysis, the IVT or the intravenous thrombolysis is by a drug which comes under the category of tissue plasminogen activators. What they do is they convert the plasminogen to plasmin. So the plasmin will go and lyse the fibrin clot and makes the fibrin FTP or the fibrin degradation products. Now, there are two drugs which comes under the TP or the tissue plasminogen activator, that is alteplase and the tenecteplase. The commonly used drug is the alteplase. Now, if you thrombolyze a patient with alteplase, early stroke, this cartoon will show you how many patients they are going to get better. So it's going to cause some side effects as well. So the patient can develop some complications such as death from the ICH or ICH with some severe disability. But a lot of patients, they are going to benefit from giving the thrombolytic drug. Right, so can we thrombolysis No, we can't. Next, right. So we can give thrombolysis to all the patients. Usually, patients should come within 5.5 hours, and then we look for the exclusion criteria. So these are the exclusion criteria from the SLMA guidelines, but some of the exclusion criteria are now taken as relative contraindications as well. So the usual dosing is it is given as a IV infusion, 0.9 milligrams a kilogram, and the maximum dose would be 90 milligrams. So 10% of the dose is given as a bolus in the first minute, and the remaining 90% is given as a infusion over the remaining 59 minutes. Now, what are the evidence we have for the use of alteplase as a thrombolytic drug? Right. So if you look at the evidence for the alteplase, mainly evidence comes from the NINS, ECAS, and the IST or the interstitial stroke trials, where they found if thrombolysis is given early, the outcome is better. So NNT is the number needed to treat. That means if you treat 10 patients, one patient is going to get better. So if you give it early, within the first 3 hours, and if you treat 10 patients, one patient is going to get better. And 3 to 4.5 hours, if you treat 19 patients, only one patient is going to get better. And after 4.5 hours, when you treat 50 patients, only one patient is going to get better. Therefore, we need to give the thrombolysis early. So earlier the better. And also we look at the number needed to harm. So that is 18. Now, if you look at these numbers here, now here when you treat 18, let's say we take it as 20. So if you treat 20 patients, one patient is going to get a ICH, but 2 patients is going to get better. That's for less than 3 hours. So 3 to 4.5 hours. If you treat 19 patients, for each one patient you are going to get, you are going to make better. One patient is going to get a ICH. Now beyond 4.5 hours, there are going to be more ICH patients compared to patients who actually are going to make better. Okay. Therefore, for intravenous thrombolysis with antiplatelets, we need to give it early. So earlier the better. But the problem is most of the patients don't come within 4.5 hours interval. Then what are you going to do? Then I mean, if you look at the numbers, about 15 to 24% of patients, they are uncertain about the time of onset, especially wake-up strokes. I mean, if you see a lot of the patients that we see in the clinical practice, most of the patients will tell you when they wake up in the morning, they had a weakness. So we don't know the exact onset of the weakness. So that is the time the advanced imaging modalities are going to be important. So here we look at the MRI, DW, the flare scans, where they can say whether patient is ischemic and whether there are any salvageable areas. That is, differentiate ischemic infarcted core from the ischemic penumbra area. So there's evidence to suggest that if you even go beyond 4.5 hours, and if you have additional imaging methods, then you can say, yes, we can go and thrombolyze these patients, or we can go for the reperfusion treatment. So the evidence is mainly for the 4.5 to 9 hours. Right, I'll just quickly go through this one. So even though we don't do it much in our country, but other countries, they are really worried about these wake-up strokes. Therefore, they do the imaging methods, and there are a lot of studies coming up now looking at whether can we reperfuse the patients who have woken up in the morning and they found that they are having weakness. So when they do the CT might not show anything. When that's fine, they can thrombolyze the patient. If not, if the CT shows some ischemia, but they don't know when the ischemia happened, so then you do an additional imaging method and see whether the patient can be thrombolyzed or not. Right. Now, when you extend the period beyond the time window of 4.5 hours, then we always run the risk of ICH. So the risk of ICH, the symptomatic ICH, I mean, when you take a different ICH, there are asymptomatic ICH which we are not much worried about. But if the symptomatic ICH, because that's going to add up to the patient's disability as well. Now, that is about 5 to 7% for IV alteplase, and these numbers actually different in different studies because they have used different criteria to define the ICH and the clinical disability. However, basically, if you look at these numbers, if the patient was thrombolyzed earlier, the ICH risk is less. But when you go beyond a particular time limit, the ICH risk goes up. And also there are other risk factors as well, especially the increasing age, history of heart failure, atrial fibrillations, and higher NIH score. High NIH score means patient has a large infarct, because large infarct tend to have hemorrhagic transformations. So those are the risk factors for development of ICH when you are going to thrombolyze a patient. I thought I'll put one slide on thrombectomy. So this is new to the stroke thrombolysis, but this is used by cardiologists for for the myocardial infarctions. This is not in the US guidelines. It is not still licensed by the FDA for the use of stroke. But UK guidelines, the newer guideline, which will come to later, in 2023, UK Ireland guideline has approved thrombectomy for the use of acute ischemic stroke. Now, what is now here the important thing is thrombectomy can be given as a intravenous bolus, whereas alteplase has to be given as an infusion. So this is really easier. And also, if you look at the trial results, the ICH risk and also efficacy are both same. And I had recently, the thrombectomy cost-wise, it is less costlier than alteplase, which I'm not quite sure about it. But if it is cost-effective, then this is something which we can try for our patients as well. Right. So this is about the intravenous thrombolysis for reperfusion. Now, what about the limitations of IVT? Now, in intravenous thrombolysis, the recanalization rate is about 10 to 25, mainly for the large artery strokes. And there are some characteristics of thrombus as well. For example, the larger thrombus, much more established, or the more established strokes, and then the platelet-rich fibrin clots, and also calcified thrombus materials. Now, these clots might not get lysed with the intravenous thrombolysis. Then we have to move further to mechanical methods or the mechanical thrombectomy. So there are so many devices which can be used in the management of mechanical thrombectomy. Now there are stents, there are aspiration devices, there are so many different kinds of devices which can be used in the mechanical thrombectomy. Right, so if you look at the research evidence, the mechanical thrombectomy has shown as it improves the patient outcome in the proximal occlusion of the large vessels in the arterial circulation. And the proximal occlusions are mainly the inlet carotid arteries or the first division, M1 division of the middle cerebral arteries, because when you go beyond M1 or the two divisions of the middle cerebral artery, then it's technically demanding, and also they run a risk of making the stroke worse or even causing the rupture of the artery, making the hemorrhagic stroke turning into ICH. And also we need a lot of technical expertise as well. However, if you look at the meta-analysis, they have shown if you do the mechanical thrombectomy for the proximal occlusions of the large vessel arteries in the arterial circulation, there's a good functional outcome. And also if you look at the numbers, the NNT is about 3 or 3 to 7. So the variation is because the different trials have used different classifications of the strokes and also different imaging methods that are used. Right, now even the mechanical thrombectomy, the improvement of the patient is depend on the time. So earlier the better. So if it is done within 6 hours, there's a good functional outcome. And when we use better or advanced imaging methods like MRI scans, and if we look at the core and the penumbra, and if we select into the patients, then the outcome of these patients are better. And when we compare mechanical thrombectomy to the IVT or the intravenous thrombolysis, the outcome is better with the mechanical thrombectomy for the large arteries. So here also the greater benefit comes earlier you do the mechanical thrombectomy. Now if you are going beyond mechanical thrombectomy, now basically these come from the UK and the US trials where they want to treat the patients who are woken up with the stroke, so the delayed presentation patients. So these are mainly for the wake up strokes where they look at different time intervals. So the 6 hours to 24 hours, 6 hours, 16 hours, depending on different trials. So they found if they do the mechanical thrombectomy following advanced imaging, there will be a benefit for these patients. But for the posterior circulatory infarctions, there's not much evidence. One thing is, it's technically a little bit, I think technically it's difficult and demanding compared to the cannulation of the anterior circulation. So it's not widely available to our patients. It is not universally available. Even in the UK, only few centers would do mechanical thrombectomy and all these advanced images. So most of the patients, they go to the intravenous thrombolysis. Other thing is the trained staff, interventional radiologist, and also still there are varying trial results showing whether to do just the mechanical thrombectomy or do the intravenous thrombolysis and then go for the mechanical thrombectomy. Right, so that is for the reperfusion therapy. And there's a set of patients, you might have seen these kind of patients, they develop a huge stroke. We can call them as malignant MC or the malignant middle cerebral artery strokes. Malignant means they are huge and they are dangerous, not they are actually cancerous. So these large infarctions tend to swell up very quickly. Now these large hemispheric infarctions, usually MC or the total anterior circulation infarctions, they become huge and there will be a lot of cerebral edema, and that tend to herniate, they tend to press on the brain, the normal brain matter, and cause transtentorial and subfalcine herniation, which can lead to death. So if someone develops this much of edema, the mortality goes up. The mortality is more than 50% for large MCA stroke going into significant edema. So these patients can be treated by doing what is called the decompressive hemicraniectomy via the neurosurgeons. With the craniotomy, they do the Buber hose and they take the skull cap out like here, and they let the edema to swell outside the brain, and they reduce the herniation of the brain. So for the mortality, number needed to treat is 2. So if you treat 2 patients, you can save 1 patient. But the problem is you always consider the quality of life. So someone having this much of large stroke and they are going to get severe disability. Someday they might not even wake up. So you need to consider and you discuss this with the family before you go ahead with the decompressive hemicraniectomy for your patients. Right. Now we look at the what is the newer guideline. So this is the newest guideline which came out in April this year, UK Ireland guideline. So whenever you see a patient with an acute ischemic stroke, you admit the patient to the acute stroke service and then do the brain imaging as soon as possible. CT can be done within few minutes, and then depending on your plan for the further management, you can go for advanced imaging like CT angiograms or CT or the MRI perfusion imaging. But those should be done at least within 6 hours from the known onset time of the stroke. So management would be, even in developed countries, if the patient comes within 4.5 hours and if there are no contraindications for intravenous thrombolysis, treat the patient with either alteplase or plinectoplase according to the UK guideline. In the US guidelines, it's a alteplase for the patients. And if the time of onset is more than 4.5 hours, where the patient is sure about the time, then if the time period is 4.5 to 9 hours, and if there's evidence of CT or the MRI perfusion or the MRI DW flare mismatch, then if they shows there's a potential penumbra that can be salvaged, then patient can be thrombolyzed at that place. But these patients still run a risk of converting the hemorrhagic infarction into ischemic infarct into hemorrhagic infarction. If not, we can go for the mechanical thrombectomy if there are available facilities are available. So that is mainly for the acute anterior circulation ischemic strokes, mainly for the proximal intracranial large artery strokes, and where the patient they can do the procedure within 6 hours of the onset. And if it is going to be more than 6 hours, then it will little difficult. They need to do the advanced imaging and also look for the aspect score and make sure the benefit is more than the harm that can be done by going at the mechanical thrombectomy. Now here they have put at 6 hours, that usually goes up to about 24 hours, not for the patients who comes who had stroke days earlier. So usually this is for about within 24 hours, or when they are woken up with a stroke where they don't know the actual onset of the stroke, but still it's going to be usually less than 24 hours. And for the decompressive hemicraniectomy, so before the stroke, patient has to be mobile and independent, and the patient's NIH score should be more than 15. That means it should be severe stroke, and also patient decrease in the level of consciousness either by the GCS or NIH's first 1A score, where the patient level of consciousness has dropped by 1. And also the CT and the infarct shows at least 50% of the brain volume of the infarct. Now let's say if you take the MCA, midcerebral areas, more than 50% of that area should be infarcted. So if the patient fulfills this criteria, we can discuss with the neurosurgeons and the family whether we can go ahead with the decompressive hemicraniectomy or not. Right, and then comes the post thrombolysis care. So this is where the stroke unit care, the stroke team comes. So the important thing would be monitor for the bleeding and the angioedema. So if the patient is going to develop allergic reaction, so the angioedema, it should usually happen in the first hour, but it can happen even few hours after giving the thrombolysis. And then monitor vitals, BP, pulse, saturation, GCS, 15 minutes for 2 hours, and then half an hour for about 4 hours, and thereafter hourly for the 24 hours. Then fluid balance and the hydration, then the patient's blood sugar management. And after 24 hours, we routinely repeat a CT and see whether there's any hemorrhage. If there's no hemorrhage, patient can be started on antiplatelet drugs if there are no contraindications. So usually the practice is start aspirin 300 milligrams given for 2 weeks, and then convert it to clopidogrel 75 milligrams and continue indefinitely if there are no contraindications. And then statins, whether the lipid profile is normal or not, statins can be started from the day 1 onwards. And then the blood pressure, diabetes treatment, and then continue the patient's regular medication the patient was on previously. And if there is any suspicion of intracranial hemorrhage, especially if the patient's GC is going down, if the patient develop any raised ICP features or the raised intracranial pressure features, patient warrants early CT brain scan. Right, I think that's all for the today's talk. So what we discussed today is how do you assess a patient who comes with acute ischemic stroke, neuroimaging from CT angiogram, then the perfusion images and MRI scans, and then the importance of stroke lead care and the reperfusion methods and the trial evidence for those, and also what is new and what is recommended in the guidelines. Okay, thank you, and I'm happy to answer if there are any questions.
Forum is open to questions.
Thank you. Nice presentation. Full overview of this acute management. So, I just want to ask about this connected place. Now, as you said, the UK European guidelines they are coming, not in the USA.
Yes.
My feeling is we should also switch over to connected place for various reasons. One is cost factor.
Yeah.
Right? Other thing is very easy to give. Just a bonus. Other thing you have to wait for 1 hour. And you said every minute you lose about 10,000
Yes.
euros.
Yeah.
So within that 1 hour, you are losing euros.
Yes.
It starts acting
Quickly. Yeah.
Right? The other thing, none of the studies have shown any inferiority compared to other place.
No.
Or
Both are equal.
better outcome.
Yeah.
And in fact, some of the studies have shown it's more effective in large vessel occlusion. Here, in our country, we don't do thrombectomy also.
Yeah.
Do you think if we get a patient where we suspect a large vessel occlusion, like middle cerebral artery inside, rather than giving LTEC place, we should give connector place?
It's available. Yes, sir. We can give it only.
It's available.
It's available.
In fact, we used it for the last few months. Now it's available. LTEC place was not available in the hospital. Then we were forced to use it. We have some concern about the legal matters also.
Yeah, once in the guideline is there, so at least we have some cover to give it. But Peradeniya is other way around. We have LT place, we don't have TNEC place. We have only few vials, so we have to keep it for the patient comes with MI. So we still give mainly LT place for the stroke patients. But if it's
I can't give you permission immediately.
First of all, thank you very much for the comprehensive lecture. My question is, unfortunately, that below the guidelines, more than 90% are acute stroke patients. Various reasons, maybe the patient factor, maybe the logistic reason. So they are better candidate for thrombolysis.
Yeah.
So the 90% of the stroke patients, so we manage the medical load, conservatively. So in that case, we have a kind of management guideline we are recommending for our US. Those patients are not eligible for thrombolysis.
I mean, if I come to the first comment that you mentioned, well, we have to educate the public and have to get the patients quickly to the hospital. So at least we can thrombolyze these patients. So it's a large number of patients, even in developed countries. Only a minority of patients are actually thrombolyzed. Even the patient who goes to the thrombectomy are even smaller. So most of the patients are there. They are also still there managed with the antiplatelets and the statins. Ideally, these patients, they need the stroke unit care. It's not just a side bed where you put the patient and then you say it's conservative management, you send the patient home after 24 hours. So that is not the ideal management. They need a stroke unit care. But the problem is we don't have stroke beds even in the country. I think Corona has a bigger stroke unit where they have got, so they have a 20 patient beds, right? Corona they have more than 20, but it's better than us. But thing is, it's already full, so we can't take the patient because it's like we send the patient to Ragama for rehabilitation. It's difficult to find a bed because once a patient comes to stroke unit, they are going to stay with us for a few weeks. So what they do in other countries is they select the patients as young strokes and the older ones. So patients who are older than 65, they usually go under the medics or the geriatric the team where they manage them in the geriatric or the medical wards. Whereas the young stroke patients who are under 55, 60, depending on the hospital, they manage in a stroke unit. So where but the care is almost same, but in a stroke unit there will be more personalized or more patient-based care which can be given. So simple things that we can do in our setup would be, one thing would be educate the family. So most of the time we don't talk to the family and we don't explain to the patient, it's not the patient, the family about the patient's outcome. So if it's a large MC stroke, but usually what we see is, we can't blame the journalist as well. We say something like this. Rather than that, we should tell exactly what is going to happen to the patient. So if it's a very small stroke, very tiny, like an infarction, we can reassure the patient. If it's a large stroke, we have to tell the family what is the probable outcome. And then we should try to minimize the risk factors for these patients, like smoking, and then the hypertension, diabetes management, and then arrange early physiotherapy and occupational therapy and speech therapy. So those are things what we can do in the medical wards. And then once the patient is stable, we can send the patient home and then arrange physiotherapy where they can come and get it done from the closest hospital. Yeah.
First month is a very crucial to the stroke patient. You know, the first stroke.
Yeah.
So what your recommendation to you are doing the one antiplatelet or the first month you are recommending the one antiplatelet?
First month.
First month, yeah.
First month,
right.
Right. There are different trial evidence for that. Now, the European studies, they tried only single antiplatelet, whereas there's a Chinese trial which came out a couple of years ago called Chance trial, where they gave 2 antiplatelets, aspirin plus clopid. They gave for 3 weeks and then 1 week, 2 weeks. Dual antiplatelets, that is aspirin 300 with clopid 300. It's a large dose for a week, and then they converted to aspirin 300 and clopid, aspirin 150 and clopid 75 for a total of 90 days. So they found that is better. We don't know exactly how it's going to work for our patients. Therefore, if you read the US guidelines, they mention give single antiplatelet, but in small print for Chinese population, you can refer to the Chance trial and you can give 2 antiplatelets. So it's very difficult to give a scientific answer for that. But given the fact that giving 2 antiplatelets can make the risk of ICH goes up. Therefore, you have to balance out whether the patient is going to get an ICH by just treating patient with a stroke, ischemic stroke, or are you going to give single antiplatelet. So our practice is we give single antiplatelet, that is aspirin, high dose, 2 weeks, that is 300, and then we convert to single antiplatelet agent. But if you can do advanced imaging, or if you can do the carotid imaging and also the CT angiograms, and if there are intracranial thrombosis, intracranial atherosclerosis, then there's a place for giving best medical management advice, giving 2 antiplatelets. Otherwise, most of the trial evidence giving single antiplatelet has a lesser bleeding effect, even though giving 2 antiplatelets has a better, better compared to one single antiplatelet. I hope I answered the question.
If patients are out of the thrombolytic window, and suppose they have developed cerebral edema,
Right.
place for 3% sodium chloride in that instance. Cerebral edema, what are you going to do with that?
Right, so there are 3 types of cerebral edemas, right? There's a hydrostatic cerebral edema, that is when there's a block in the CSF path, you have to shunt the patient. Then there's cytotoxic, and then there's a vasogenic. So to get the vasogenic is seen in cancers where you have the secondaries. So for that you give steroids. So what you see in the stroke is a cytotoxic cerebral edema, where it's a osmotic therapy that you should do. So you can give either mannitol or you can give 3% saline. Probably 3% saline is, if you send it faster, you might make the patient develop osmotic demyelination. So you can give it, but it's going to be a little dangerous. But giving mannitol is, I feel, is a little safer. So do you want to add anything for that?
Regarding the dual antiplatelets, where they gave it NIH score was low.
Lower.
Or less for transient ischemic attacks. They didn't use, I think, dual antiplatelets or NIH score 5 or more. As I said, this was short period, 1 month. And,
the population is different, and there are a lot of
intracranial atherosclerosis. There's probably a place for dual antiplatelet. You can demonstrate by doing that.
Just to ask you, but he was commenting on 3%.
Yes.
As you might get distracted into a different thought. We see a lot of patients being given 3% saline for hyponatremia,
Right.
BTU or in other setups, many, we have seen a number of patients who are developing osmotic devaluation syndrome. So it's very risky when someone is having just hyponatremia alone. It's hyponatremia due to something else.
Yeah.
Because the ones who are giving do not see the outcome. After 2-3 days only they develop osmotic devaluation syndrome.
Yeah.
The patient is unconscious, drowsy, and we don't think of even osmotic devaluation syndrome. Patient is drowsy, we think the aspiration or
Stroke.
stroke can go worse. So it's difficult thing to detect. So it's very risky as opposed to give 3%. The guideline is that, say, if someone is hyponatremic, within 24 hours, hyponatremic only that you give. 24 hours or 48 hours, I can't remember. If it is acute hyponatremia, only that you give 3%. Say, if it is a long-standing, no one knows whether someone is hyponatremic within 24 hours or whether hyponatremia has been going on. Had it been hyponatremia for a long time, maybe 3-4 days or 5, rapidly correcting hyponatremia immediately precipitates osmotic devaluation syndrome. That is by the way.
Yeah.
And as to the dual antiplatelets, it's not just the chances of pre-thrombosis. The occurrence of when the patient has other contraindications to antiplatelets.
Yes.
Gastric ulcers and hemorrhoids and all that has to be considered for the sake of the medical diagnosis. So, as of our practice, I think we are practicing the single antiplatelet is fairly safe.
Yes.
That's what I feel.
Unless they have other indication of, for example, if the patient is already in a cardiac stent, of course they are going to be on 2 antiplatelets. So then we can consider that one. But from the only the brain point of view, single is enough.
Even then, after 6 months to 1 year,
they make it
go to
single antiplatelet.
There will see a lot of patients from clinic. They are on dual antiplatelets. Coming with septal hemorrhage, coming with GI hemorrhage referred to gastroenterologist who upper GI on. So we do not see that aspect of it unless you are really in a medical ward. Thank you.
Making matters worse, I was saying 3 antiplatelets.
Thank you, Sajitha. It's a wonderful talk. And what's the best time to start antihypertensives when you discharge patients from the medical ward? So when the blood pressures are very high, then you will start antihypertensives. But suppose that is blood pressures around 100-200 towards the day 3. Is this the time to start antihypertensives, or can you wait some more days to start?
After 3 days, madam, the risk of making the matters worse is less. So after 3 days, you can start antihypertensive. If the patient is already on, of course, you can contribute them. Otherwise, if it's a newly diagnosed patient, after 3 days, you can start antihypertensives.